So intensive chemotherapy has been the mainstay of treatment of fit adults for a very long time, and it essentially consists of drugs which kill rapidly dividing cells with the aim that the leukemic cells in the patient's marrow be preferentially killed and the patient achieves a complete remission, defined as fewer than 5% leukemic cells in a bone marrow test. Intensive chemotherapy, of course, has a lot of toxicities associated with it. It makes your neutrophil count low, your platelet count low, with the risks of infection and bleeding. It can also give you a sore mouth, you lose hair, often diarrhea and vomiting. And so patients, certainly during their first course of chemotherapy, are almost certainly treated as an inpatient. It's only really recently that we are thinking in fit and unfit patients that we may not always need to use intensive chemotherapy, which is a bit of a blunderbuss. And in selected subgroups of patients with mutations in particular genes, particularly the gene FLT3, the IDH1 genes, we now have targeted therapies that, either in combination with intensive chemo or with venetoclax and azacitidine in older patients, is very effective. And this is softer, more gentle treatment. It targets the leukemic cells preferentially. It doesn't always exclude the complications of a low neutrophil count and platelet count, but it certainly doesn't have many of the other toxicities that intensive chemotherapy has.